let's get started. So hello and welcome. We're all very excited that you could join us this evening, particularly for me. This is my first live or in-person meeting that I attended since the onset of COVID. So this evening, we are very fortunate to have three distinguished experts to tell us about the future of oncology in general and specifically for our community. First, Dr. Eric Weiner. He's the director of the Yale Cancer Center and physician-in-chief of Smilow Cancer Network. He's also the president of American Society of Clinical Oncology. And if you guys don't know what that is, it's a pretty big deal. Okay. Our own Dr. Barbara Ward, she's the chief of surgery at Greenwich Hospital and the director of Greenwich Hospital Breast Center. Dr. Cropp is the chief research officer and director of clinical trials office at Yale Cancer Center. And for those people who don't know me, I'm Sang Lee. I'm one of the Smilow oncologists here at Greenwich Hospital, and I'm the section head of oncology. Our evening format will be straightforward. Each presenter will give us a brief presentation followed by Q&A. And I'm going to kick off this session with an introduction on multidisciplinary cancer care. So since the inception of oncology as a distinct discipline of medicine in the 1960s, there have been three ways of treating cancer, namely surgery, radiation therapy, and chemotherapy. And historically, these treatment modalities have been used in various combinations and sequences to treat cancer patients with the simple goals of improving the quality of life and longevity. And you can argue that that's the goal of all of you physicians in general. Many in the audience are aware of the advances in oncology. Numerous therapies like immunotherapy and CAR T that we have read about in the newspaper or in the medical journals. And similarly, in the fields of surgery and radiation oncology, there have been and are ongoing great advances. And I don't want to get bogged down in details, but I think many people have heard of minimally invasive surgery, robotic surgery, as well as maybe some of you may not have heard of things like radiosurgery. And radiosurgery is a radiation therapy that is so specific and targeted that it can mimic surgery, delivering a targeted beam of energy to a very specific area. So all these advances have been made in medicine and oncology in the last 20 years. And so it is more important now than ever before that all these different forms of cancer treatment are involved and consulted in care of our patients. And joining these more, let's call it traditional arms of cancer therapy are the localized therapy that are often delivered by our interventional radiology colleagues. These specialists are able to deliver therapies, whether it be medication, radiation, as well as heat, to a very, very specific area of the body. In the past, some advanced cancer patients were deemed to be incurable and treated with chemotherapy with goals of palliating their symptoms. But now with these advances in surgical, radiation, and local ablation techniques, we're able to greatly extend the survival, and in some cases, cure advanced stage cancer patients. So again, it is extremely important that all cancer patients be assessed by physicians of different specialties to provide the optimal care. For many years, it has been a standard practice to present and discuss new cancer patients in a forum that we call the tumor board. And this is a meeting where all those doctors who are involved in making the diagnosis, radiologists, gastroenterologists, pulmonologists, and pathologists, as well as those who deliver therapy, surgeons, radiation oncologists, and medical oncologists meet to discuss and come up with a consensus. All these specialists bring together their collective experience and knowledge, as well as new technique that the other specialists may not be aware of. So one of many things that I've learned in the 20 years of my practice is that every patient is unique in their own way, And in order to make sure that we are delivering the latest and the best care, we need to tap into the collective knowledge and resources of all of our colleagues. But there is one more very important aspect of cancer care that I should not overlook, and that is the palliative care. So palliative care is a relatively new discipline in the cancer care. And many people have the idea that palliative care equates with end-of-life or hospice care, but obviously this is not accurate. Our colleagues in palliative care specialize in addressing often overlooked needs, psychosocial, emotional, nutritional, and financial, as well as symptom management. And this applies especially to those patients who are undergoing curative therapy that are often very physically demanding and challenging. And providing adequate support so that they can complete the curative therapy is crucial. Now, I'm also leaving out many of our supportive staff, and I think I don't need to mention everybody by detail, but all the nurses, our nutritionists, the physicists who are involved in delivering the therapy. I think they should all be, be acknowledged for the important role that they serve. So over the years, oncology has become much more of a team effort. The days of an oncologist by herself or himself trying to provide the complex needs of our patients are long in the past. Our patients now live longer, they live better through this collaborative effort of all the different medical specialists and our supportive staff. And with that, I will turn over the podium figuratively to Dr. Weiner.
There we go. Can people hear me?
Yes, very good.
Yes. All right, great. Well, my colleague Ian Cropp and I wish we could be there, but it was just impossible to get down there this afternoon. And it's really a little creepy because at the moment, somehow the way this is working is I'm just looking at myself, which I really don't. Let's figure out a way around this. In any case, I'll try to ignore my own countenance. So cancer care has changed and will continue to change in the years ahead. And I think you've already heard some of the ways in which it's changing. And I'm just going to highlight a few. And then I'm hoping that there'll be questions that get at some of the specifics. So first, cancer care is fundamentally multidisciplinary. And, as was just stated, it's not up to any one doctor to take care of a patient by her or himself. And it's typically teams of doctors that often involve surgeons and medical oncologists and radiation oncologists, and of course, pathologists who, when I was in medical school, I thought they had the most boring job in the world. And now I understand just quite how important they are to everything that we do. And radiologists and psychiatrists, as well as nurses and social workers and dietitians and everyone else. So it's always a team. Number two, and I think we've seen this over the past several decades, and it's going to continue to be this way. There is more and more involvement of patients in their own care. My theme as president of ASCO this year is partnering with patients, the cornerstone of clinical care and research. And I think for most of us, taking care of patients is really entirely a partnership. I think that's what's best for patients. I actually think that's what's best for doctors too. And it's one of the ways that we can protect ourselves from burnout is by feeling like our patients are our partners. Third, and this is something that is evolving over time, but cancer care is becoming more and more subspecialized. The time when it was possible to take care of patients who had many different types of cancer and where your specialty was just being an oncologist or being an oncologic surgeon have really come just about to a close. We still have examples of it, and I know that the doctors, the medical oncologists in Greenwich do their very best to take care of a range of patients. Although even in Greenwich, the limited number of doctors there tend to subspecialize in one area or another. And in the future, I think that's something we're going to see more and more, such that breast cancer patients are taken care of by breast cancer medical oncologists. GI cancer patients are taken care of by GI cancer specialists. And finally, as part of all of this, and this is where the Yale-Greenwich relationship becomes so very important, cancer care is going to increasingly be provided through networks. Most people don't want to travel an hour, 2 hours, 3 hours to visit a major cancer center, wait 4 hours to get their visit, and then wait longer to get some sort of treatment. Care closer to home is clearly something that is good for patients, good for families, and just makes sense. But the best way we can do that is if we have networks, and if we have places like Yale or Columbia or Penn or name any place, Mount Sinai, who are working with groups of doctors in smaller communities. And the advantage there is that some of the expertise that's available at the major centers can then be very easily transmitted to people who are working in smaller hospitals. And patients can get the same care that they would get in a major center, but in a much more smaller, much more comfortable, much more intimate environment. For that matter, I think that from a medical oncology standpoint, it's very likely that there's going to be more and more cancer care delivered not just in the hospital or in an outpatient infusion area, but actually in people's homes. And this is something we're also going to have to get ready for. One of the real pluses for me as the relatively new cancer center director at Yale, I came here all of 7 months ago tomorrow, is that we have this incredible network. And so it's not just about directing the cancer program at Yale, it's about directing the cancer program across a network of centers across the state. We have 14 different Smilow centers scattered across the state. One of them is Greenwich. There are others down in your general area, but then we have places in Torrington and in Hartford and in many other locations. And the real plus is that there's the possibility, as I've referred to, of trying to help people get care that's convenient, doesn't feel as disruptive, and is much closer to home, with doctors who can take advantage of everything that we might have at a major medical center. And in my mind, that's the very best possible care. So we at Yale have enjoyed our relationship with Greenwich. We look forward to doing more with Greenwich in the years ahead. We very much hope that you're going to get approved to build a great new facility. And I look forward to answering any questions that you have. At the end.
Thank you very much, Dr. Weiner. And with that, Dr. Ward.
Okay, I failed to acknowledge that Dr. Ward and I were trainees at about the same time. I just look about 30 years older than she does. She was a surgical intern, and I was a medical intern at Yale at some time in the past. But again, I just haven't aged very well. Barbara, it's really good to see you.
Thank you. You as well, Eric. And interestingly, somebody said to me, doesn't he look a lot like Dr. Fauci? Did you ever get that?
I got that yesterday in the elevator. I got it on a Boston street corner when someone was taking my picture. It happens roughly once a week.
Well, you're doing a great job in two different diverse areas. Hello, everyone, and thank you for joining us. I'm proud to share the podium, so to speak, with Drs. Lee, Weiner, and Cropp. And thank you, Dana Marnane, for organizing us. So I've been asked to comment on the increased prevalence of cancer in the Greenwich and Fairfield County. And so the data that I'm going to discuss briefly comes from the Office of Strategy Management for the Yale system. So again, the Office of Strategy Management. So that's a think tank for forecasting health needs for the future. And so again, they're strategizing, they're helping us to think about what's headed. So quoting the Office of Strategy Management, they say, in the next 10 years in the Greenwich-Stanford region, nearly all cancer types show growth rates between 20 to 26%, with breast, gynecologic, and urologic cancers remaining the most prevalent in our region. And these numbers are higher than the rest of Connecticut, which is estimated to be 6 to 12%. So to further understand that, however, we have to know what prevalence means. So from an epidemiologic standpoint, so what's prevalence? So it's important to understand that prevalence is the total number of cases in an existing population. So that includes patients that were diagnosed with cancer in the past and are surviving. So it's not completely bad to have a high prevalence if you're alive and doing well, but had a history of breast cancer. But at the same time, it got, I think, the system's attention to realize that in Greenwich specifically, we're going to have increasing needs in the future. Now, prevalence is different than incidence. Incidence is what are the new cases diagnosed in a given time. So that's incidence, and that's typically calculated on an annual basis. So just to throw out the estimated numbers for Connecticut from the American Cancer Society, breast cancer tops the list at 3,350, prostate cancer 3,310, lung cancer at 2,760, colorectal cancer at 1,550, and then cervical cancer, interestingly, only 120 cases. Lung cancer is the leading cause of death. It tends, hopefully not permanently that way, because there are new strides for lung cancer treatment. But again, these are sort of the general numbers that we're looking at. And Connecticut, kind of for each cancer, we're a little higher than most places in the country for all cancer types. And not really exactly sure why that is. Sometimes I wonder if it's the fact that we have such a robust cancer tumor registry. I don't think we miss any cases being captured in Connecticut. If you don't know, the Connecticut Tumor Registry was the first tumor registry in the country, established in 1941. I mentioned cervical cancer as sort of a reference point. Prior to the pandemic, a group of us from Greenwich Hospital traveled to Nepal to provide education and surgery regarding breast, esophageal, and lung cancer. Dr. Boyd, who's in the room, participated, Dr. Waters, Hollister, and Elsa Raskin, one of our plastic surgeons, and Dr. Mariana. Although we hopefully helped them, I was saddened to hear that the most common serious cancer there among women was cervical cancer, right? There's no widespread Pap tests, et cetera, et cetera. It's like a whole different situation. And therefore, we realize we're incredibly blessed to be living where we are, right, with the way we're screened. And yet, why are we here tonight? We have a cancer problem. Connecticut, again, has a higher incidence of most cancers than other parts of the country, and our area is predicted to have a significant increased prevalence in the years ahead. As I mentioned, this includes patients alive with cancer or a history of cancer, but they'll need treatment and they'll need follow-up. While we want complete cancer prevention, we need to remain on the forefront lines of early detection and treatment. For breast cancer specifically, the majority of cancers diagnosed at our breast center are stage 0 and stage 1. And that's great news for survivorship. But these patients still need treatment and they still need follow-up as well. And then for the more advanced cases, the more serious cases, the HER2 positive, the triple negative cancers, we need the clinical trials to continue to look for cures. So in closing, we have a strong history of cancer treatment built on the shoulders of the likes of Dr. Arthur Rosenberg, Dick Hollister, Phil McWhorter in surgery. And I think this is best summarized by the plaque. If you walk into the Cohen Pavilion, you'll see a plaque on the wall. And I don't think many of us actually look up to see what it says. But it states, to the donors whose extraordinary support has made it a reality, to the caregivers who offer expertise and compassionate care. And this, in my mind, includes the amazing nurses, radiology and radiation technologists, among many others in that building. And then, importantly, to all who come here for comfort and healing. So as we grow with the Yale Smilow Cancer System, we can't lose any of that. And it is what sets us apart. So thank you for your attention.
And our fourth speaker will be Dr. Cropp.
Thank you, Dr. Lee. So my name's Ian Cropp. I'm a medical oncologist, and as you heard, I'm also the director of the clinical trial office here at Yale. I got here 6 months ago, so 1 year after Eric, and 1 month after Eric. And my talk is supposed to be about the remarkable advances in cancer therapy. And it really is no exaggeration to say that cancer treatments are now dramatically better than they were only 20 years ago. Back then, almost all of the drugs we gave were chemotherapy, which are drugs that essentially are designed to kill any fast-growing cell. Now, those therapies are effective, but because normal cells also can grow very quickly, such as blood cells or hair cells, these chemotherapies tend to have a substantial amount of side effects, and cancers can become resistant to chemotherapy. So things change. The reason why we've had these remarkable advances is because about 20 years ago, we started realizing that the best way to treat cancer was to try to understand what were the drivers within the cancer cell that was causing the cancer to grow and become cancerous. And because of advances in science, we've been able to identify these types of drivers. For instance, in certain lung cancers and leukemias, there's a mutation in proteins within those cancers that cause, which essentially are the main cause of those cancers. And once it was realized that it was those mutations that were causing the problem, it led to the development of pills that specifically block those mutations. And these pills are now widely used. We call them targeted therapies because they target something specific within the cancer cell. And they're very effective, and they tend to have relatively few side effects because they're targeting something specifically in the cancer that's not driving normal cells. We even now, recently, there's a set of targeted therapies that are essentially designer drugs or designer molecules that were developed using technology that started at Yale and now is in a company called Arvinas, and these are essentially targeted inhibitors that can be made against virtually any protein within a cancer that is a driver. And these new pills are being tested in clinical trials, now open in Greenwich and prostate cancer and other cancers. So these targeted pills blocking specific mutations have been a big advance. Another very interesting approach has been to use what's called antibodies. You've probably heard this term, antibodies. Antibodies are basically proteins that your body immune system makes that are very specific for one particular protein. Your immune system makes antibodies against viruses, against bacteria, and we now can make antibodies in the laboratory and in factories against virtually anything. We made them against COVID, and there are now antibody therapies against COVID because they're very specific for the COVID virus. You can also make antibodies against cancer proteins, and that is now done. And what's been the real advance is taking these antibodies and actually linking them to a chemotherapy. So attaching a chemotherapy to these antibodies. And so what happens is if you inject one of these antibodies against a cancer cell into a person, that antibody will travel through the bloodstream and bind to all the cancer cells, bringing the chemotherapy with it. And since the chemotherapy is attached to the antibody, it doesn't go and damage normal tissue. So it's a way of specifically delivering chemotherapy right to the cancer cell. So essentially, you're taking a non-targeted drug like chemotherapy and making it targeted with this antibody. It's kind of like a guided missile. And these drugs have been enormously effective. There was just a trial in breast cancer where in patients whose cancer had become resistant to 6 different drugs already, this drug worked in 97% of patients in terms of providing some benefit in controlling their cancer. These antibody conjugates are now widely used in many types of cancer. They're in new ADCs that are in clinical trials at Greenwich right now. And this has enormous potential, and you'll continue to see a lot of progress in that area. And then lastly, perhaps the most exciting new development is what's called immunotherapy, which is a term that I think people are starting to hear more and more about. And it's essentially, the idea is our immune systems are designed not only to kill bacteria and viruses, but also to kill cancer cells. But when a patient has cancer, it's a sign that somehow that cancer has suppressed the ability of the immune system to seek out and attack that cancer. Just about exactly 20 years ago, there was the discovery of how these cancers are suppressing the immune system. And that led to the development of drugs that now block that process so that the cancer can no longer suppress the immune system. If you give a person that drug, it allows the immune system to wake up and attack the cancer. And these drugs have had enormous effectiveness in patients with melanoma and lung cancer, 2 cancers where other therapies really had failed to work. So these immune therapies have really revolutionized the treatment of many of these hard to treat cancers. And these drugs are also widely used in clinical trials and widely used in clinical practice. So really we're just going to see more and more development of new very targeted therapies. The pace of discovery is getting faster and faster. And I would just say, from my role as director of clinical trials, that none of this development of new drugs would have happened without patients volunteering to participate in trials. It's a way to get access to the very latest treatment. We have trials both in New Haven, and many trials are now open in Greenwich, and we certainly would recommend people asking their oncologists about the availability of trials, whenever you're thinking about a treatment for a cancer. So, and again, also happy to take questions later.
Okay, thank you very much. With that, we will move on to the question and answer. Okay.
I have a question.
Okay.
Should I come here or there?
Why don't you just ask? Well, you could come up and use the microphone, or maybe just use this microphone. Might be easier, perhaps. Is it on?
Yes.
Yes. All right. Here we are.
Dr. Lee, you have to use the microphone.
I have to.
Want me to go here?
No, you can talk to
Okay. I have a Back to the Future question for Dr. Weiner. The headline here from that other medical school, Harvard, reads, and this is from the 1940s, hurts to use nuclear fission in cure for cancer. Dr. Saul Hertz conceived and brought from bench to bedside the medical uses of radioactive iodine, which is called a theranostics, meaning that it's a radioactive drug. It seeks out the cancer and then targets the cancer in terms of treating it. And I'm wondering here in Greenwich, if theranostics is part of the future in terms of what's going to be offered here.
So both Dr. Cropp and I did used to be at that other medical school a few months ago. So radioactive iodine, to my knowledge, is useful in one setting, and that's in the treatment of thyroid cancer, where it's still used today. Theranostics is an area that has helped a limited number of individuals, but to date hasn't gone all that far. It has been useful in the treatment of cancer that has spread to bones in men with prostate cancer and certain other malignancies. There's talk about using it for the treatment of neuroendocrine tumors, which are a very specific kind of cancer that are not terribly common. I think there are potentially other roles. It's not a therapy that plays a major role in the treatment of most cancers today, but that could change in the future. I think that I will tell you that I think that the future is more likely to emphasize treatments that are probably better tolerated than most of the theranostics, and are effective against the cancer without being damaging to the patient.
Dr. Warner, I think you may have addressed this next question in your portion, but since it was asked, I'm going to direct this question to you, and I will also make a comment on it. The question is, how will Greenwich Hospital's advanced cancer care compare to other renowned hospitals such as Memorial Sloan Kettering?
Memorial Sloan Kettering is a great place. I have many, many colleagues there. I would like to think that in the years ahead that our program at Yale will be absolutely premier. And I think it's hard to compare one place with another. And by no means are we attempting to be a freestanding cancer center like Memorial Sloan Kettering or Dana-Farber, where I had been for many years. But I think what you can expect from Greenwich is that Greenwich will have the care available in the years ahead that is available at Yale and is absolutely state-of-the-art, delivered by outstanding clinicians with the availability of clinical trials, so new and cutting-edge therapies. You know, I think that we just have to make that work. I think Greenwich is a great place. I think that partnerships between smaller hospitals and bigger hospitals very often lead both to being even better.
Thank you. So I would like to comment on that because, as you know, I've been practicing here for 20 years, and I have had many of my patients. I've collaborated with Memorial Sloan Kettering as well as other cancer centers. So, you know, when you hear Memorial Sloan Kettering, you think, oh, well, what do we know about that? Well, they deliver excellent cancer care. And this is not just because that's what they advertise on the radio. They have a great collective experience. And if you have either read or watched a television series, The Emperor of All Melodies, you know, they have been in the forefront of cancer research since the 60s. And you know what? So is Yale. As a matter of fact, one of the, I guess you would call founders of oncology is Dr. DeVita. And Yale has an excellent collective knowledge and experience. And one of the strength of Yale is their excellent clinical research and advances. And when we think of these academic centers, we think of, well, what can they do that local oncologists cannot provide? Well, specialized care, newest and the latest in cutting edge therapy. So Yale and Smilow Cancer Care, that's exactly what they can provide. The phase 1 clinical team, phase 1 clinical trials team at Yale is, I mean, I think I could argue that it's probably the best in the country. Many of the innovative therapies have been developed through research at Yale. And the fact that we're able to tap into that experience and knowledge and provide care in our community without having our patients need to travel to, an hour plus into New York or further away, I think it's a great advantage. There's a saying that you can't have your cake and eat it too. Well, that's exactly what we want. We want to have the experience. We want all the things that the tertiary care centers can provide, but we want it here. And that's exactly what we are striving to do, and that's what we hope that we can accomplish. Anybody else wants to have a comment on that?
I'll just say one more thing, which is that there are lots of good places to get care. For those of you who have children who have or will or are applying to colleges, there are lots of good colleges and universities. And I think it's often in the eyes of the beholder. And I would never say that someone should or shouldn't go to any high-ranking academic center. And for that matter, I think that it's really important to be at a place where there are clinical trials, not necessarily because the best care is always in a clinical trial, because if we knew for sure it were the best care, it wouldn't be a clinical trial, it would be standard of care. But because oftentimes it's the place where you're going to find the best doctors.
Hi there, Justin Down with the Fairfield County Business Journal. Something that was mentioned early on was the possibility of a shift towards in-home care
Yeah.
for a lot of cancer patients. I was wondering if you could speak to the possible implications for how business is done and how the approach to care will change as a result of that, and how widespread do you see that sort of thing being? Obviously here in this region, a lot of people would probably be able to afford that standard, but I'm curious if you see that becoming very broadly applicable.
I guess that's for me. So since I mentioned it, I think there are going to be certain treatments that can be given at home and certain treatments that can't be given at home. It probably doesn't make a lot of sense for someone to be receiving a treatment at home that requires one-on-one, or maybe one-on-one would make sense, but requires the presence of a nurse who could also be taking care of 3 other patients at the same time. That's just economically not going to work. And for that matter, if it's a treatment that could be associated with certain acute complications, that might not work. But increasingly, a lot of our therapies are going to be easier to administer. They're going to be subcutaneous drugs or intramuscular drugs or oral drugs even. And I think we're going to see a shift away from these large infusion units, which has been the hallmark of most cancer therapy. And we're going to see more done at people's homes, in smaller centers, and how it exactly plays out. I think we haven't totally figured it out. But if you compare 2022 with 2000, there are far fewer patients with cancer who are in the hospital getting therapy. We still do have some people who are hospitalized, but it's really the minority. And so I think you can only imagine what it's going to be like in another decade. And of course, none of us can really predict exactly what treatments are going to be available. But the accelerated pace at which therapies are being developed seems to continue on.
Thank you. And just one follow-up. Could you speak to roughly when we might start seeing that become an increasingly common trend? About a decade out, it sounded like you said?
So I think we're already seeing it in some cases.
Mhm.
And I think that some of it is also a change in culture. We're used to giving a lot of these therapies in the hospital. And by in the hospital, I mean in infusion units in the hospital, not necessarily as an inpatient. And in many other medical areas, more and more of treatments that aren't so different from the treatments that we give to patients with cancer are actually done in the home and are self-administered by patients.
Thank you.
Okay, next question. What advances have been made in monitoring for recurrences? I can start with that, and perhaps my colleagues can join in. There is a relatively new technology. So until now, monitoring for recurrences. So what that means is, in certain select cases, repeating imaging studies like CAT scans, which are frankly very cumbersome and can subject our patients to unnecessary amount of radiation. So there is a limited role for repeat scans. Some people have utilized blood tests, whether it's simple blood counts, chemistry, or much more controversial use of a blood test called the tumor marker testing. By and large, use of tumor marker is debatable. There are certain select cancers, for example, testicular cancers, where use of tumor marker is absolutely necessary. But there are limitations to them. So there is a new advance, and is testing for something called circulating tumor DNA. And the principle is relatively straightforward. If there are any cancer cells that are left in the body, some of these cancer cells, as they die off, they release a fragment of their DNA. And if we're able to detect the amount of the DNA, we can perhaps detect an early recurrence. There is a test that is being utilized, and I believe the FDA has approved the use of this testing, I think within the last year or so. And this is how to be a much more specific and sensitive testing for recurrence of cancer. I think this is just one example. I think there are similar technologies that are being developed, not just for recurrences, but perhaps even in the future, detecting very early cancers as well. So I think you should all just stay tuned and just wait for the sciences to reveal to us what will be available in the future. Dr. Cropp, do you have any comment about this?
Yeah, no, thanks for asking. And you're right that the circulating tumor DNA is a very promising technology. It's incredibly sensitive to detect, incredibly small amounts of DNA that come out of tumor cells that may still be scattered around the body. And so it's very clear that you can detect cancers with the circulating tumor DNA. What was not clear is whether that leads to any benefit to the patient, whether detecting it, at a particular point in time with this ultrasensitive test, or waiting months later and detect it with a standard test that we have now, because it may be that having circulating DNA there at very low levels, the cancer may never grow. It may just be dormant. So what's happening now is that there are clinical trials going on, including some at Greenwich, where people who have different types of cancer, different stages of cancer, can enter a trial where the circulating DNA is assessed for, and then depending on the results and depending on the way the trial is set up, whether there would be a change in somebody's treatment based on that. But that's what we really need, is to prove that that just because we can detect this DNA doesn't really benefit patients. And even though you can go buy the test right now, it doesn't mean that it's actually beneficial. And so that's where we need clinical trials to really kind of delve into that. But it is a very interesting technology, and the technology also is going to get better over the years.
Great, thank you. This next question is for Dr. Ward. Could the reason behind the numbers being high in Lower Connecticut be due to the population being responsible about testing, their medical care in general, mammogram, for example?
I think that they're asking a great question. So in other words, that we have a compliant patient population. Dr. Lee, would you agree that, yeah, so, yeah, I think there is something to be said for that, that there's no question we have a compliant patient population in general, that women are very dedicated to their annual mammogram. Even in the midst of the pandemic, we didn't close the breast center because patients were coming. Right? We weren't even necessarily recommending that they come during the height of the pandemic, but they came. And then, of course, we needed to be open for patients with, new masses and new cancers. But yes, and I think that it really points to the partnership that the hospital enjoys with the community. That they've, obviously I can speak to breast cancer the best, but I know when it comes to colonoscopies, it's pretty much standard of care that people know they're going to be getting a colonoscopies now beginning at 45, not just 50. And it leads to earlier diagnosis. We also have a population really where we don't see as much lung cancer, as some other places, and that again speaks to, in general, a healthy population. I can't say that obviously that's for all comers, but some of these numbers, as I was preparing to speak tonight, there are counties in the United States that have such a high lung cancer risk of, like Kentucky, and then it just reflects lifestyle, and so, but I agree that part of the prevalence issue is early detection. Therefore, we have lots of survivors, right? And that's a good thing. It's not all that, but the survivors still want to be watched. To be honest, I saw close to 16 people today, and almost everybody was fine. My daughters laughed and they said, "I'll say, how was your day?" And I was like, "Well, everybody was fine." And they're like, "But Mom, that's a good thing, right?" But as a surgeon, obviously I stand ready to help the person that needs my surgical skills. But it's reflective of the great relationship, the symbiotic relationship I think we have with our patients. I was wondering if I could direct a question to Dr. Cropp. So can you provide any recommendations for how we can increase accrual to clinical trials? I know one of the issues that we have is, we don't have 1 billion triple negative breast cancers. Well, we're not going to be able to participate, in high numbers in those trials. But beyond that, how do we, make sure we're getting the message out to our community that we have clinical trials and that it's important to us at Greenwich Hospital to offer clinical trials?
Yeah, I think that's a great question, and I think studies have shown that patients are interested in clinical trials, and oftentimes the limitation is just that they don't hear about them, or they don't hear about them, at the right time. So I think it's a lot about education, and I think we as the healthcare team need to be thinking about trials for patients when they come to us. In terms of, there are websites available for patients to get access to trials, find out where trials are. But I think it's a hard thing to do from a public education campaign. I think it's really incumbent upon us as the healthcare team to let patients know about trials that are available for them. You know, obviously a well-informed patient is always a good thing, and you know, it's great when patients come to me or come to us and say, hey, I'm interested in a trial. But I think we need to be the ones who, you know, if they don't know that, they don't know to ask, we need be the ones to offer.
Well, since Dr. Ward got to ask a question, I'm going to ask a question too. And this question is for Dr. Weiner. Dr. Weiner, can you give me an opinion as to how you feel that the COVID pandemic has affected cancer diagnosis and treatment, or just any relationship between COVID and what we do in oncology?
I think it's had a pretty major impact in some ways and not in others. And of course, you know, it's affected our entire society. From a screening standpoint, we know that there were delays in screenings as a result of COVID, and there's been concern raised that may possibly lead to later diagnosis and potentially smaller chances that people will ultimately be cured. In truth, I think that while it's clearly time to get back to cancer screening as usual, I think delays of a few months or even a year are probably, in the end, not huge. And my hope is that this will not be a major factor. I do think, though, that the pandemic has made us rethink how we deliver care, how we use telemedicine, how we approach clinical trials in terms of the frequency of visits. And so in that sense, I think it's actually, in some ways, a positive impact. I think it's made us realize that a lot of the ways that we thought we just needed to function could be questioned. And so in that way, I think that it's probably had an even bigger effect. Of course, the other major issue is that associated with COVID has been a huge decrease in the number of people in the healthcare professions who are currently practicing. There are many nurses who have left, leading to yet another nursing shortage. There are physicians who have chosen to retire early. And I think that in the long term, and even in the not so long term, this is leading to a workforce shortage, and from a nursing standpoint, for many hospitals, a workforce crisis.
Thank you. Okay, I have a question for Dr. Ward. Can you explain the importance of survivorship in the future of cancer care?
Oh, wow, that's a great question. And standing in the back of the room here is Heather Studwell, our survivorship coordinator. I'd like to give her the microphone. She can speak, but we recently had our survey with the Commission on Cancer and the National Accreditation Program for Breast Centers, and we were able to really feature the significant dedication to survivorship that we've had for a while. It kind of started out of the physical medicine department, and early on now, they wanted to see our patients prior to surgery, right? Recognizing that they're survivors from the beginning. We want to see patients early on. We want to follow them through their treatment. We want to be engaged with them going forward. And quite honestly, Heather has been really very instrumental in allowing that to happen. Coming in on Saturdays to see a post-op patient, I can't tell you how many things running from her office over to the physical medicine department. Today, she was trying to coordinate a COVID test on the day that the patient was coming in to see the physical medicine person preoperatively because that patient's coming from New Jersey. And it's that sort of personalized care that leads to the whole spirit of survivorship. And so just speaking to survivorship from day one, the other important thing that the survey, I think, helped us to think about for the future, though, was patient engagement long-term, right? To what about our 10-year survivors? They can actually provide hope for the newly diagnosed patients, right? And to include them back into survivorship, that don't kind of let go of your long-term survivors and engage them in the process with the newly diagnosed patients, and also to include families. It's not only the patient, right? It's the caregivers, it's the families that need that survivorship support too. Going forward, I think it provided kind of a vision for us that we're really off to a good start. It's one of the things that I think partnering with Yale, they've recognized that at Yale Hospital, we're sort of ahead of the game when it comes to that pre-op, they call it prehab, seeing patients before interventions are started. And so we're really blessed to have an engaged physical medicine team that has then involved others too, the nutritionist, the social worker. And so I just think that's a really good question. Heather, if you would like to add anything. I did okay. But it's it's a mindset as well, I think, that the whole team is involved. When we talk about the multidisciplinary care team, these other helpers, so to speak, from physical medicine, our genetic counselors, they're at the tumor board. We met this morning at 7 a.m. They're there at 7 a.m. For these multidisciplinary meetings. And then the nurses sort of talk again a second time of who's struggling right now, outside of that tumor board, and who needs additional help and making sure that those things are provided. So it's still a work in progress. We want to learn more. And I think we'll work together, with the whole Smilow system to improve upon survivorship and new ideas that others might have. Along those lines, with regard to what I was asking Dr. Cropp, was celebrating patients who participate in clinical trials, that somehow they get noticed, they get even if it's a t-shirt, or something, that, hey, I was in a clinical trial, and sort of ideas for that celebrate survivorship along with clinical trial participation.
Great, thank you. So I know it's running over late. I hope we have time for one more question. And the question, and I will ask Dr. Cropp and Dr. Weiner. Question is there another alternative to chemo on the near horizon, or is it here to stay? Dr. Cropp, can you field that question?
So, as we kind of talked about that, I think it's a great question. Chemotherapy, we still use it, and I think we will still continue to use it for some time because it certainly can have its uses, but we're using much less than we used to. We're using targeted therapy instead of chemotherapy in many cases. We're using targeted therapy with chemotherapy to cut down the amount of chemotherapy we have to use, and we're being much smarter about identifying which cancers really need chemotherapy and which ones don't. So, we now do, in breast cancer, for example, we now do a test looking at the genes of a person's cancer in the large majority of patients with breast cancer, and that gene test can tell you whether or not chemotherapy is effective or whether you can use a targeted therapy that blocks estrogen instead. And that's led to a dramatic decrease in the amount of chemotherapy that we need. So, again, it all comes back to this idea of understanding what drives the cancer, having drugs that block these drivers and using those to instead of chemotherapy, or reduce the amount of chemotherapy that we're using. So a lot of progress has been made in that regard.
So I would agree. And certainly from a breast cancer standpoint, for operable breast cancer, early stage breast cancer, we probably give about half as much chemotherapy in 2022 as we did 15 years ago. And that's the result of carefully designed clinical trials. And it's not just breast cancer. In patients who have metastatic melanoma, which in the past was a almost uniformly incurable diagnosis, there are now somewhere in the range of 30 to 40% of patients who receive upfront immunotherapy, no chemotherapy, and are alive and cancer-free many years later. So cancer treatment's changing. It's changing a lot. And doesn't mean that all of these targeted therapies have no side effects, but we're getting much, much smarter. And that's through a combination of basic science research and clinical trials. And all of that is going to lead to being in a very different place in another 10 or 15 years.
Thank you very much. That's actually a perfect answer to the, to the topic of our discussion tonight. The point was to discuss the future of oncology, and I don't know whether Dr. Weiner had planned it that way, but he just ended it in an absolutely perfect manner. That was great. I don't know whether he planned it.
Total accident.
Planned the question, but anyway. So Dr. Weiner and Dr. Cropp and Dr. Ward, thank you very much. I think this was a wonderful session. And I also thank everyone for participating in this evening's discussion and meeting. Thank you.
Thanks for having us.